Good morning, everyone. Good morning. Welcome to Pediatric Grand Rounds. We're going to get started right now, even though I think there's still a few people outside because we've got a lot of material to cover this morning. I'm Kathy Bendel from the Division of Neonatology. I think it's either a sad or appropriate consequence or coincidence that this is our topic for discussion this particular morning. And when I walked into the building this morning, I was met by the smiling face of one of our community pediatricians, Tim Anderson, a longtime, very valued colleague and wise friend, who suggested that we really need to take a moment this morning to think about all of our vulnerable colleagues and people here in the United States today. With that said, we'll move forward. This is going to be a two-part Grand Rounds this morning. I'm going to begin with a very brief introduction to equity, diversity, and inclusion in our Department of Pediatrics, and then turn things over to my co-speaker, Dr. Ann Phibbs, who will do the majority of this presentation. So why this topic? Well, President Kaler has endorsed diversity as a core value for our university. And Dean Jackson has made the work of diversity a key priority for the medical school. I was humbled and honored when Joe recognized my interest in advanced studies in this area and asked me to assume the new role of Associate Chair for Diversity, working alongside Tony Moran in her role as Vice Chair for Faculty Development and Diversity. But this is not work that one does alone. Much like my clinical work on the NICU, this is a team sport. We all share responsibility for equity and diversity. It's everybody's everyday work. Everyone can be an ally, or as I like to say, we really need to be accomplices. And I am very fortunate to have a wonderful group of accomplices. Meet the many faculty members who share this passion and have joined me on the Equity, Diversity, and Inclusion Committee here in the Department of Pediatrics. As you can see, we have representation from most divisions. New members are always welcome, so let me know if you want to be an accomplice too. This is a fluid working group to identify important issues, strengths and weaknesses, along with priorities for the department in the areas of equity, diversity, and inclusion. You will be hearing more from me in the coming months about our work. The enthusiasm expressed by this group was amazing and still is to me. They are committed to not only addressing the standard concerns regarding numeric representation and access, but to incorporating equity and inclusion in our educational curriculum, research endeavors, and in addressing healthcare disparities among our patient populations. This is not about numbers or closing certain doors, but rather about opening doors for all to feel welcome and valued in the department. It's about celebrating our diversity. It's about expanding our culture of inclusion so that everyone is an important part of the fabric of our department, because we are stronger together. With that said, let me show you a bit about our numeric representation. The next three graphs will show you the limited data that I was able to obtain on racial demographics. In all slides, the blue bars represent our pediatric group. The red bars are University of Minnesota Medical School makeup, while the green and purple bars represent demographics for the Twin Cities and Minnesota as a whole, respectively. There are many different ways to classify underrepresented groups, but for the sake of simple comparison with the Minnesota numbers, the classifications presented here are the ones used in the last U.S. Census. So starting on the left, we have the Black or African American group, then moving to the right, the American Indian or Native Alaskan group, then Asian, which is a very large group, Native, Hawaiian, and Pacific Islanders next, followed by Hispanic, Latino, and because this is a self-identified data, there's a choice of other for anyone who did not want to indicate any of the specific categories. Finally, the last group indicates those who identify as white. I'm sure it is no surprise to anyone that Minnesota is predominantly white and that the Twin Cities is somewhat less so. But as you can see, that in each of the 5 underrepresented categories, the department numbers are only higher than the state for the large Asian group or the catch-all other category. Now, this graph includes anyone and everyone on the PEDS payroll, so it does include staff and trainees as well as faculty. When you look at faculty alone, the numbers change, and we become even more white than the state of Minnesota as a whole, with no increases in any of the non-white categories over the department as a whole. When you look at trainees, the percentage of non-white department members increases, but note that the major increase is really in the other category, both for the Department of Pediatrics and the medical school. We could have a whole separate discussion about why individuals chose that category, and Anne may also shed some light on it during her presentation, but it is clear that most of our limited diversity is in our non-faculty staff and trainees. When we look at gender, here women are shown in red and men in blue. Minnesota on the far right is divided evenly between men and women, while the faculty in pediatrics are a bit more than half female. But that is the norm for pediatrics nationwide. Now, I have to say we have come a long way. When I was a medical student 30 plus years ago, I could name every woman on the faculty. Not because I have such a great memory for long lists of names, but because I knew the half a dozen or so myself very well. I was only the second woman in the division of neonatology, and I replaced the first. For the first 5 years, or 20% of my career, I was the only woman in the division. Hard to believe that now when you look at our current numbers. With respect to rank, there are still more women and members of underrepresented in medicine groups at the associate and assistant professor levels. The numbers in parentheses along the x-axis indicates the percent of the total faculty at that particular rank. We are increasing our numbers at the level, let's see, will it go back? Guess not. Oh. We are increasing our numbers in the levels of the assistant and the associate professor, or as my husband likes to say, we are starting to build a bench so that we will have leaders in the future in this department that are more diverse. The Department of Medical School could not provide me any more information on additional categories, and we all know that diversity is about far more than race, ethnicity, and gender. We have no solid numbers with respect to individuals identifying as LGBTQ, those with disabilities, or breakdowns by any other category, such as age or religion. But at least this gives you a bit of an idea of what we look like as a group. We are very fortunate here at the University of Minnesota to have an exceptional Office for Equity and Diversity. They are an amazing resource for programming, help with recruitment and retention, and a voice on this campus to remember everyone counts. They also have a phenomenal education program directed by our next speaker, Ann Phibbs. These programs are open to all at the university, but many have also been tailored for the medical school. Their seminar on implicit bias in search committees and hiring will be offered here on this campus at least twice in the next year, and I encourage and expect all of you involved in hiring to attend. Anne also leads a wonderful team offering a series of workshops that lead to a certificate in equity and diversity from the University of Minnesota. Many of our staff have taken this outstanding course, and I am one of the few faculty who has obtained an advanced certificate. One of the most exceptional seminars in the course is about being an ally, and Anne is here today to offer a modified and condensed version of this seminar. She has done this for other departments, along with the Graduate Medical Education Office. John Andrews arranged for all the program directors to participate in this. And I want to warn those of you who like to sleep through grand rounds, this will be an interactive exercise, so get ready to leave your comfort zone. We welcome Dr. Ann Phibbs.
Great. I should have you at all of my trainings to warn people not to sleep through them. So thanks so much, and helpful to get that snapshot. And I just want to thank Kathy for her leadership. All that she's doing makes a huge difference to have someone with that kind of passion and commitment in a particular department. I don't want to say a lot about the election other than to say that part of what we do in the Office for Equity and Diversity is, if nothing else, remind folks that we all move through the world differently, depending on our social identities. So I woke up this morning and realized that the person who was elected president might actually take it upon himself to take away my ability to be married as a lesbian. So I'm 54 years old. I was in a long-term partnership for 25 years that produced 2 kids, and I never thought in my lifetime I'd be married. But I did get married a few years ago when it became legal. And so for me, that political landscape shift has a profound impact on my life. And as a white person who has white privilege, it's incumbent upon me to think about what does it mean to be Muslim today, knowing that we've also elected someone who actually supported keeping Muslim folks out of this country, and around immigration, et cetera. So I don't want to, we're not supposed to get political, but the point really, though, is to just recognize that things impact all of us differently depending on our social identities. And really being an ally is paying attention, in particular to things you don't have to pay attention to. And that's part of what I want to get at. My goal today is to have you come away understanding the Office for Equity and Diversity and really the University of Minnesota's key frames, how we understand this work, how important it is, including how we can address microaggressions and microinequities through being an ally. Of course, I want to point out that being an ally can be challenging and complex, and so we want to address that. I'm going to give you an opportunity to practice acting as an ally, because we'll have a couple of scenarios where you'll have an opportunity to chat with some colleagues about what might I do in this situation, and then to identify next steps you can take. I always say when I train, and I literally train hundreds of times every year, I'm pretty much doing it constantly, that this work is lifelong. And I think in terms of thinking about all the people who have put a lot of work into this particular presidential election and other kinds of races. And of course, we saw the first Somali American also elected to public office, which is tremendously exciting. So that this work is fundamentally about a long game, realizing that we're not going to just have one public policy shift and everything changes, but recognize that if we are truly going to be an ally and care about inclusion and care about equity and diversity, that we need to be doing this all the time. These are our grounding assumptions. I'm not going to, because I really am condensing quite a bit into this short amount of time, I'm not going to review all of them, other than to point out that this work is fundamentally about being in community. And I will just say briefly, my training is, I moved here 30 years ago to get my doctorate in philosophy from the U, which I did. And in many ways, being in higher education and having a doctorate has showed me that we are, those of us in higher ed, and I would argue also in medicine for that matter, are rewarded for individualism and expertise. Am I right? I mean, at the end of the day, it's your degree, it's your CV or your resume, it's your expertise that you're called on to present about or to teach about. And yet, this work is fundamentally about neither of those things. It's really about being in community, because it doesn't work to just say, well, I'm going to study diversity for the next year and I'll be an expert on it. That won't happen. You need to be in community, in particular with people different from you. And also recognize that you need to speak about things you'll never be an expert on. So I can talk about my lesbian identity, and I've directed GLBT programs offices here and at other institutions. That was always easy for me to talk about. Talking about race and racism and ending racism as a white person was a lot harder. It took me a lot longer to get there, but I think is equally as important that we find ways to talk about things that we may never be an expert on. And in that way, we're kind of asking you to do things that you haven't always been rewarded for. I am just going to point out that we all are doing the best we can, and that part of doing this work of equity and diversity is sometimes making mistakes. And then just to reiterate what Kathy said, this work is everyone's responsibility. So it doesn't work to just say, well, we've got a great staff of 120 folks working out of the Office for Equity and Diversity. We're a small city here at the University of Minnesota, and certainly in the medical school, we need everyone to see that this is part of the work that you do. So I'm going to start in with a little bit about microaggressions and talk about how those of us who are marginalized because of our social identities, how those microaggressions and microinequities affect us. And then I'm going to have you talk a little bit about your own social identities and your own experiences with microaggressions. I'm going to tease apart very quickly the difference between bias and prejudice and oppression so we can get to an understanding of privilege and how that's connected to being an ally. We'll have some scenarios and next steps. You can see why I'm talking fast. That's a lot to do. So this is a website from called microaggressions.com. And it's a blog that seeks to provide a visual representation. So they just ask people to share their experiences. I just want to read what they say about this. Each event, observation, and experience posted is not necessarily particularly striking in and of themselves. Often they are never meant to hurt, acts done with little conscious awareness of their meanings and effects. Instead, their slow accumulation during a childhood and over a lifetime is in part what defines a marginalized experience. And there are more and more people doing work around the effects of these kind of microaggressions and inequities on health, right? So why do we see health outcomes for example, for African Americans, even those who are middle class, even those who have access to health care that might be different from middle class whites, partly because of the effects of racism and how this affects people. So what I did was I went on this website and I pulled out all the examples that were related to medicine, and I want to read through them just to get an idea of what some people put out as their experiences. While studying for a medical school parasitology exam about infectious diseases, a classmate says, "Why are we studying all these diseases that are only in Africa? They don't even have any history." My advisor at a top medical school told me that in order to advance professionally, I should act more like what people expect from an Asian woman, more demure. When taking our biracial son to the emergency room, my African-American husband makes mention of his urethra when discussing my son's illness. The white middle-aged male doctor says to him, "Where did you learn that word?" As if there is no way that my husband would know such a medical term. Made me feel angry, insulted, and degraded. I was standing in the cafeteria of a major academic medical center wearing shirt, tie, and the same white coat that all my other medical school classmates wear with a stethoscope. An older white lady tapped me on the shoulder and asked, "Excuse me, do you work here? I'm trying to find the soups." And even once I fully turned around, it never occurred to her that I'm a medical student, not a cook. I'm a black male medical student in a major Northeast academic medical center. Some of you may have heard President Obama share the story that both he and Michelle have had the experience prior to when he was actually president and surrounded by Secret Service of being dressed up for a fancy event, coming into the event, and immediately being taken to the kitchen because he was assumed to be help. And I've heard him share that many of his colleagues who are African American professionals have had similar experiences. In the hospital where I take classes, there's a resident who never calls me by my name. He always calls me little wild critter, even though I have told him not to do it, and just laughs it off when I get angry at him for it and tell him to stop. I'm a 21-year-old female medical student. He's a 27-year-old resident. Makes me feel angry, disrespected, not taken seriously. In my emergency medical training class, one of the questions on our exams read, "What does healthy skin look like?" The expected answer was pink. When I'm healthy, my skin isn't pink. And this is a 18-year-old in a university class. Made me feel overlooked and marginalized. Lecturing physician, are any of your fathers orthopedic surgeons? 10 minutes later, are any of your mothers or sisters hospice nurses? In a medical school lecture, it made me feel like traditional gender roles still dominate, even in a mixed gender graduate school class. Male medical student to another, I didn't see you paying too much attention during this lecture. What are you, gay? Overheard after anatomy lecture on female genitalia. And my last slide. You must be new. They keep getting such cute nurses. I heard a medical student was coming in to discuss my medications with me. Where is he? Said to me when I, a female medical student, entered the exam room of this elderly man to discuss his diabetes. And finally, the last one. Anytime I see the doctors at my college's health service clinic, doctor, are you sexually active? Yes. Any chance you could be pregnant? No. Are you taking birth control pills? No. Do you use condoms? Nope. Doctor beginning to look concerned. Is there a medical reason you can't become pregnant? Me, not that I'm aware of. Looking more concerned, now speaking in a condescending tone, then how do you know there's no chance of pregnancy? Me, last I checked, my female partner would have a hard time pulling that off. So what I want to say is it can be tempting to go, well, this isn't scientific data. These are anecdotes, right? But let me just share my experience that mimics some of this and to ask you to think about whether you would believe me when I tell you my experiences. So as I mentioned, so I have a 2-year-old at home and then I have these 2 adult kids. And with my oldest, who's 25 now, when he was a baby, we were in seeing a pediatrician, a man we didn't really know. And so we explained that my partner Deb, ex-partner now, but had given birth. We explained this to him that we were both co-parenting. We very much saw ourselves both as mothers. Explained our whole situation. We had a man who was the father, blah blah blah. And so he's talking to us, and he forgets this, right? So he wants to know who's breastfeeding, which I think is a perfectly reasonable question. But that's not what he says. He looks right at us and he says, "Oh, I forgot. Can you tell me again who's the mom?" Okay. So in one word, the. Right? He reinforced, because it's like, okay, that's an honest mistake, we could say, but it doesn't have just the impact of being an honest mistake on me, because I'm trying to parent as a non-biological lesbian mother in a world that says a real mother is the one who gives birth or who has adopted their child. We don't really have 2 mothers. Every child needs a mother and a father, all those kinds of things. And so I was kind of erased. And the other point is I never went back to that pediatrician. But fast forward 20 years, and I'm now at a new pediatrician clinic, right? This is 20 years later, and my partner brings our daughter in, and after the 3rd time of the pediatrician saying, "Mom and Dad," she literally says, "I don't know if you read our file, but Lois has 2 moms," right? And I could go on with the stories that I've had of medical professionals who don't do their homework, who just kind of default. And again, is it in and of itself a horrible case of egregious homophobia? No. But is it good clinical practice? And does it make me feel like I want to work with that person and trust them and disclose to them? No. And so in this way, I think this paying attention to social identities and to microaggressions is absolutely about being a better clinician, a better practitioner. So someone who's going to pay attention to this is what we call an ally, and here's the definition that we use. An ally is someone who's willing to pay attention to, but also take action around the social, economic, and political differences and inequities that attend to people based on what I've been referring to as social identities: race, ethnicity, age, class, sexual orientation, gender identity, gender expression, disability, religious or spiritual identity, and nationality. Not even an exhaustive list, so you can see why this is lifelong work. So what I want you to do, because I often frame these workshops as people often come wanting diversity training saying, tell me how to work with those people, right? Maybe tell me how to accommodate someone with a disability, or I now have someone who's transgender on staff and I want to make sure I do things right. And what I'll say is, that's admirable, but our work is not so much about how you deal with those people as who you are. How do you move in the world with your social identities? And in particular, with your privileged social identities. What does it mean to be male, to be white, to be able-bodied, to be heterosexual, cisgender, or not transgender? And how does that impact the care that you give? And so along those lines, in our workshops, we ask people to think about their social identities. So I'd like you to just pair up with one person sitting next to you and chat for a few minutes about these questions. With what communities are you most comfortable? And are there identities you know the most about? Are there particular identities and communities with which you're less comfortable? And the point is not to say, I win, it's a contest, I know I'm comfortable in 15 communities. No one's comfortable in every community. It's when we don't know where we're uncomfortable or we don't think about it, we get in trouble. So the third thing I wanted you to chat about is, have you ever witnessed or experienced a microaggression? And if so, what happened? So I'm going to give you a few minutes, again, to pair up with someone sitting next to you and have that conversation. So I'm just going to give you a minute to wrap up your conversation. So I'm going to bring us back together, and I want to ask if anyone would be willing to share if they've ever witnessed or experienced a microaggression.
I can share a microaggression that happens pretty frequently. It's when I'm with male colleagues, and they're referred to as Dr. X, and I'm referred to as Michelle.
Oh, thanks for sharing that.
My son is in a single-parent household, and he had a word scramble on the computer that said, "My father is nice, and so is my mother."
Right, the assumptions we make about everyone's family situation. One more, oh, Danny, right, I think.
My children are black, and when we first moved into Como Park, someone threw red paint all over the sidewalk and rode in front of our house, as though someone, had been run over.
Wow.
There.
Sometimes we're not sure if these are micro or macroaggressions, right? So I'm sorry that you experienced that here, yeah.
As a senior resident, when I was a senior resident a few years ago, I would walk into a patient's room with a medical student, a white male, and the patient would say, "Hi, doctor," to the medical student, and I would be the nurse with the bandana on.
Right. Thanks for sharing that. Danny?
Kind of an awkward situation, but I recently got engaged, and so I wear an engagement ring on my ring finger, and patients will see it, and they will ask me, "Congratulations on your engagement. What does what does he do? What is your fiance? What does he do?" And kind of walk down that pathway, and it puts me in a very awkward position because I don't know if I should say, "Well, my female partner," because who knows what, kind of what their landscape is. So that's always a little awkward.
Right. Yeah. So then you have to figure out if you're going to come out right then and there, which I'm sure you wanted to have to figure that out right then.
Yes, several times not anymore, but in the past, when I'd go to faculty gatherings, people would always assume that I'm the graduate student, and I was not a faculty member.
Right. My colleague, Dr. Michael Goh, who is from Singapore, shares that he has yet to go to a graduation ceremony where he's not assumed to be graduating. And in fact, at one point when he was, he has his doctorate, he's wearing his hood the way you're supposed to wear it after you've earned your doctorate. He had an usher come up and tell him that he wasn't supposed to be wearing it that way yet. And so he just talks about who it is that what we assume about people. There's another, there's a video that I show where there's a geneticist who's African American. And he says, when I walk across campus, everyone just assumes I'm the basketball coach. No one ever assumes I'm a scientist because I'm an African American man. So what this points out, and thank you to all of you who shared, my guess is there's just many more that we could pull out, is that we walk in the world differently. It impacts how we're viewed, how we're treated. And it brings up the idea that having an ally there, having, for example, a male colleague be able to say, "Oh, actually, this is Dr. Phibbs," right? Instead of when they're calling you by your first name, or having someone who notices these things can and offer some education can be very helpful. I'm not going to go through this I am going to go through this quickly. I'm not going to go through it at length, but I'm sure you all know this. But it is important that we understand the difference between bias and prejudice and oppression, because this is where we're seeing pushback. So we're seeing more and more white students talk about feeling like they feel oppressed. I have a colleague who works with white students, and they come in looking for scholarships. They can't find many scholarships, and so instead of saying I feel frustrated or angry that I couldn't find scholarships, they say I feel oppressed because all the scholarships are for students of color. Or I think about Kim Davis, the person who worked county clerk in Kentucky, who would not have wanted to give me a same-sex marriage license. And we see this movement on the part of the organized religious right to say that making someone like that as a county clerk gives someone like me as a lesbian a same-sex marriage certificate, or a marriage certificate, not a same-sex one, but just a marriage certificate, amounts to oppression of people who are Christian. And so we're seeing oppression used in ways that we in the Office for Equity and Diversity don't see it as appropriate. I don't believe, and we don't believe, that there's such a thing as reverse racism or reverse oppression. So there can be bias and prejudice, which is just, any kind of negative judgment formed without just ground. So anyone can be biased and prejudiced, including around social identities. So many years ago in the LGBT community, which I belong to, as I mentioned, we used to use the word breeder. Some of you may have known that. I never used to say it, but it was a word we used for straight people, right? Ironic. I have 3 children, right? But it was this way to push on straight people. Again, I didn't use it because I just didn't think it was right, but I knew people who did. I don't think it's the right thing to do. I don't think it's fair, but I don't think it's oppressive. Likewise, if you have a person of color who says something hurtful and biased about a white person, I don't necessarily support that either, and I think it can be hurtful. But it's not the same as oppression, because oppression is when we pull in institutional power, and that becomes really important to recognize that we don't have a history of limiting access to our institutions for white people because they're white. Right? And now white people may have all sorts of lack of access because they're poor, because they're GLBT and white, because they have a disability, etc. But it's not because they're white. Likewise, we don't really have a history of denying people access to institutions, whether that's the media or education or voting or government, etc. Because economic institutions, because they're Christian. With the exception of some anti-Catholicism that we have a history of, we don't really see keeping Christians as Christians out of institutions. And so when people say, well, we're beating up on white guys and we're now, white people are oppressed, I have a really hard time seeing that, because what we don't see is that people of color and American Indian folks have had this power to keep white people out of institutions. And so it becomes really important to pay attention to the history and the context. Why do we have scholarships for students of color and American Indian students? Why do we have scholarships for women? Why are we trying to get more women in the STEM fields? Why, and recognizing that it's because we've had both kind of public policy barriers and institutional barriers, and also a lot of attitudinal barriers. And so this is just an example of some of the things that we've been up against. I do believe that many people understand oppression. It's kind of hard to miss that we have a history of slavery, a history of genocide of American Indian people, that et cetera, in our country. But I think sometimes it's tempting to say, well, I'm over here being a good person. I might be male, I might be white, I might be heterosexual, I don't have a disability, I'm middle class, I'm respectful to everyone, I put my head down, I do my job, I'm being neutral, right? So there's oppression and I'm over here being neutral. And the challenge is that the flip side of oppression really isn't neutrality. It's really privilege. We can't really get away from it. So even though I want to say, look, I'm a good person, I worked hard to earn my PhD, I wrote a bad book, best description of a PhD I've ever heard, 208 pages, but it was done, right? So I like to think I did it because I earned my PhD because I'm smart and I worked hard. And probably some of that's true, but I've come to realize it probably helped a lot that I looked like every one of my professors, because they were all white, that I grew up speaking English in the United States, that I had a middle-class education, and that in many ways I was someone who was seen as someone who could earn a PhD, right? And so I often talk about a both and frame, that we can see that we deserve things because we've worked hard and we're good people, but also recognize that some of the ways we move in the world really has been shaped by our social identities. And in that way, recognizing privilege becomes an important part of being an ally. Just a slide about some thoughts about privilege kind of being designed not to be seen. This is Peggy McIntosh, who's wrote an important piece in the late 80s about it. And that really the whole point of being an ally is not to feel bad that you have privilege, but to move past shame, guilt, and blame to say, what am I going to do about it? And I want to show you a short clip. So this is just that we talk about being an ally as an ongoing process that involves self-reflection, an openness to new ideas, a willingness to listen to and believe people's lived experiences, commitment to ongoing education, and a willingness to take action and take risks. And I want to just share a short video clip from Joy DeGroux. She's a social work faculty out in California who does a lot of work on the effects of slavery on the black family. She's not going to talk about her research. She's actually just going to share an experience as an African-American woman and what someone did that was for her being an ally. So I'm going to pull that up.
My sister-in-law, who's half black, half white, but looks white, blue eyes, whiter than most white folks, very white. She and I, we kind of grew up together. We raised our children together. So they're first cousins, and it's a wonderful, very, very multicultural family. So we're going in a Safeway one day, and Kathleen, my sister-in-law, is in front of me, and she's, writing a check for her groceries. Now, my daughter, who at the time was 10 years old, was standing with me, and I was directly behind her, getting ready to get my groceries. So Kathleen comes up, and the checker, who's a strawberry blonde, freckled, very delightful, warm, the checker, this young woman, is talking to Kathleen. Hey, how you doing? Isn't it a nice day today? They're just chatting up, and says, yes. So Kathy writes her check, and she steps off to the side with her groceries because she's waiting for me. Of course, again, Kathleen looks white, right? So I come up. No conversation. She looks up at me. Absolutely no, just little chatter. And I write my check. My daughter, however, is 10, notices immediately the difference in how she responds to me. So I write my check, and she goes, I'm going to need 2 pieces of ID. At which point, my daughter looks at me, and she gets very, very embarrassed, and tears are coming up from her eye, like, Mommy, you're not gonna let her do this. Why is she doing this to us, right? So I'm trying to figure out what I should do, because behind me are 2 elderly white women, right? And I'm thinking, okay, so then I become the angry black woman, right? And they're gonna be, and I'm just trying to second guess all the drama. I just give her the 2 pieces of ID. I said, some things you gotta choose your battles, right? And then it gets worse. She pulls out the bad check book, right? So this is the book that shows the people who've written bad checks. So she starts searching for my license in the bad checks, at which point it's just out of control now. Just as I'm standing there trying to decide what to do, and it's really deeply humiliating. Now my daughter is in full-blown emotionally upset, who's 10. My sister-in-law walks back over. And she steps in and she says, excuse me, why are you doing this? And the checker goes, well, what do you mean? She goes, why are you taking her through all of these changes? Why are you doing that? She goes, well, this is our policy. She goes, no, it's not your policy because you didn't do that with me. Oh, well, I know you've been. She goes, no, she's been here for years. I've only lived here for 3 months. And so at this point, the 2 white elderly ladies go, I can't believe what this checker has done with this woman. It is totally unacceptable. At which point, the manager walks over. So the manager walks over and says, is there a problem here? And then my sister-in-law again responds. She goes, yes, there is a problem here. Here is what happened. So you see, she used her white privilege. And even though Kathleen is half black and half white, she recognizes what that means. And she made the statement. She pointed out the injustice. And she, as a result of that one act, influenced everyone in that space. But what would have happened? I can't know for certain had the black woman said, this is unfair. Why are you doing this to me? would it have had the same impact? But Kathleen knew that she walked through the world differently than I did. And she used her white privilege to educate and make right a situation that was wrong. That's what you can do every single day.
So you've been handed some scenarios. There are 2 of them. And what I'd like you to do, these are situations where I just want you to think about what might you do in this situation? How might you act as an ally? And I think what I'll have you do is read through both of them and then talk about the one that you find most interesting. And ideally, if you could try to gather yourself into groups of about 4 or 6, or even turn around or move a little bit, that would be helpful just to get a few more voices. But read through them, and then I'm going to give you a few minutes to chat about what you might do in those situations. So I'm going to give you 1 minute to wrap up your conversation. Oh. So I'm going to bring us back together because of time. So I'm going to bring us back together. And I just want to see by a show of hands, how many of you talked about number 1? All right. And then by a show of hands, 2, about another. Okay. So we'll start in with number 1. I'm going to read it. You're part of the resident selection committee as you're discussing different applicants. One faculty member says, I think we should consider Chris T. Their academic record is strong, and I appreciate how one of their nomination letters addressed their long struggle with anxiety and depression. I agree that Chris has really demonstrated a lot of resilience as a medical student. Another faculty member responds, do you really think we should be rewarding someone's mental health condition? I don't think that should ever keep us from accepting someone into residency, but it shouldn't be a reason to accept them. I know we want to consider residency applicants in a holistic manner, but isn't this going a little bit too far? So what did you all talk about? And do we have that? There we go. Thank you. Yay. Thank you, Danny. Just a couple of folks could share what you chatted about with that. How might you respond? What is the best way to understand and address a potential resident's mental health condition?
I don't know if it's really about rewarding. I think it's more of, I would address it as a less of a reward type situation and more of this is just a demonstration of personal character and how one has overcome a difficult situation in their lives and how they could potentially bring that as an asset into the residency program.
Okay, great. So one of the things, thank you for that. One of the things we talk about a lot in the educational work I do is that notion, the idea of reframing. People put stuff out there, and how can we reframe it from, in this case, a kind of sense of reward to more that this shows character, resilience. Thanks. Other comments about what you discussed? Maybe someone on this side of the room. We've got a hand back there.
So part of what we were discussing is that the only reason it seems to me that this is a question of if this should be rewarded is because this is a mental health question. If this was any other medical diagnosis, this wouldn't be a question. And so acknowledging that mental health conditions are legitimate and that people need to work and put effort and their own medical treatment into that in addition to other types of therapies, et cetera, I agree that this is something that we look at how a person has dealt with it, how they are moving on from their personal struggles, and that it's not rewarding, it's acknowledging their character and their abilities. And we need to do that for all of our applicants. So we don't know what else we're looking at for other applicants, but absolutely I take this as a positive for them.
Great. Thanks for that. And part of that is maybe recognizing that mental health conditions and mental illness is stigmatized, that we don't treat it the same way. In many ways we should, as other kinds of illness, or other kinds of disability that might be more physical and less focused on emotional or mental. So I appreciate those reframes. I'm aware of time, so I want to move to the second one to see if anyone has some comments about that one. You're standing around chatting with a group of staff and faculty. The conversation is focused on work, but then goes to other topics. Staff member mentions how they just ran the Twin Cities Marathon. A white faculty member replies, remember how Black Lives Matter threatened to shut the marathon down in 2015? I'm so glad they didn't. I just can't see what they would achieve. I got stuck this summer with a bunch of activists shut down 35W, and all it did was make me mad. Then looking in the direction of the only black person in the group, who is staff, the faculty member continues, no offense to anyone, but tactics like that only make people frustrated. Anybody in the room, by a show of hands, ever heard a comment about frustration with the tactics of Black Lives Matter? Just curious? Okay, yeah, so we touched into something here. How might you reframe that for the folks who talked about it or anyone else who wants to jump in? Because let me just say that, some of this work is about bringing in people, as Kathy mentioned, with all your demographic information. But I always remind people that when you bring people in, if you haven't done the work of the climate that you're bringing them into, then can be wasted effort. And what do I mean by that? I mean, if we bring people of color and American Indian, staff and faculty in, but we haven't addressed sometimes the ways that racism plays out, including a kind of microaggression here, looking at someone and saying, oh, no offense, but I as a white person don't really agree with Black Lives Matter. And what happens is people don't say anything, right? Minnesota, am I right about that? Sometimes, anybody seen a toddler ever try to play hide and seek? I'm hiding. And you're like, no, you're not, actually. And to me, it's the same way we do about race. I'm not saying anything, so therefore I'm creating a positive racial climate. No, you're not. We have to talk about it. We have to be open about it. And it might even be challenging your colleague and saying something like, wait a minute, this is an intense issue and we all need to weigh in on this. Or sometimes just a well-placed question, something like, yeah, all it did was make me mad. Yeah, I wonder how people are feeling, how angry people are feeling about racial injustice that's been going on for 400 years. Or I wonder what tactics would be embraced by all white people in Minnesota, right? I mean, that's a little snarky, so you got to be careful about that. But I just want to point out the idea about lending your voice. And it's not always about knowing exactly what you want to say. It's not always about feeling like you're never going to make a mistake. I'd rather see people kind of try to do something and not quite get it right than stay silent, because that happens a lot. I want to be really respectful of time. Did you want to say something, Kathy?
Well, all I was going to say, since no one offered a comment, is I was involved in a conversation like the one that was described here. What one individual said was, I think it's really difficult for those of us who have not, to tell people how to express their anger when they're people who have been oppressed and not had a voice forever. It's not our place to tell them how they choose to express that feeling.
Oh, so somebody said that. That's great. Great. Thanks for sharing that. I have a comment here. Yeah.
Yeah, so in this kind of, I've had this situation many times.
Okay.
And what I tell people is, yeah, that was my initial reaction too, but then I really thought about it and I thought, no, the point is that Black lives do matter. And then they start to think about it because, right. I tell them that the point is to get across that, yes, of course, everybody's lives matter, but it's high time that people start to realize that we haven't paid enough attention to this point that Black lives matter.
Right.
And then people start to, come around and agree with me.
Thanks. And using ourselves as examples of our own learning can be tremendously helpful. I want to thank you for spending time with me. Again, thank Kathy for giving me this opportunity, for Danny to helping out. The last thing I'm just leaving you with is I think you have a list of action plan, just things you can do. I want you to think about something you could commit to do in the next week, something in the next year, and how you would hold yourself accountable. Because guaranteed that you have a gazillion other things coming in on you that aren't about equity and diversity. So how do you keep that front and center? And I want to just point out our main website, diversity.umn.edu. We have a wonderful resource guide with all sorts of video clips, websites, blogs, articles, and books that if you're looking to, just keep this front and center for you, say, well, for the next, in the next week, I'm going to go and check out one of the videos or one of the websites. I'm going to read Color Lines. For the next week, a wonderful website looking at issues of race as they pick apart this election, or just start to commit to having conversations maybe, or being in spaces that are different from where you usually go. But at any rate, want to be respectful of your time, so thanks for having me and have a great morning.
Thank you, Anne, so much for spending time with us. And I really do want to encourage everyone to visit the website, to think about the equity and diversity workshops. There's really a lot to learn, and they're an excellent for self-development as well. Thank you.
You have been